Okay, there's a lot to work with there. I think we, as a committee, we're trying to push forward, and how can we move forward with the evidence? So I would welcome, we have plenty of time for comments, discussion, and if you could just identify yourself and use the microphone, that would be great.
Thanks. David Atkins from Office of Research at VA. Thanks. I think this framework is very helpful, and this grid of matching categories to services is really the right way to go. So I'd offer a couple of comments from the VA perspective. So first, a word of caution about the cost savings. I think anytime you're selecting patients based on utilization and cost, there's a lot of regression to the mean. I think there's a limited number of randomized trials in this area, and those generally have shown much smaller effects. We have the experience, you mentioned impact, and if you're talking about the Palo Alto project, there may be two things called impact, but we have a randomized trial in Palo Alto that showed 30% reduction in costs in the control group and in the intervention group. So I do think there's potential for cost savings. It's not going to be as big as advertised, and it's going to require targeting. And I think the second issue is that the context of care makes a huge difference on the potential for cost savings. So there are places where there are low-hanging fruit, but if you're in an integrated health system with a well-functioning patient-centered medical home, that fruit isn't so low-hanging, you know. So, and the VA has had the unfortunate experience of taking things that work really well in a kind of disorganized health system. We apply them in a health system that has already harvested low-hanging fruit, and the returns aren't as great. I think the returns for patients, for caregivers, are very important, and I think the VA continues to invest in these programs because of those values on health outcomes, caregivers. Although I'd say that our take on whether there's a lot of savings to be gathered is more skeptical. I think there's a case where it can be cost neutral if you target it and match the services. And I guess the last question is the mental health component. That's clearly been our experience that's a big factor. Are you intentionally sort of excluding the ones where that's the driver? I mean, because there clearly are there clearly are separate programs for the schizophrenic patients, where it's really the mental health conditions that are driving most of these secondary effects, and because that's a very different care team than what you would design for a team where the non-mental health medical problems are different, and that's the way we have separate programs for home-based care, but separate programs for the seriously mental ill.
That's a great set of comments. A couple of things that I'll say that our group wrestled with, both in the larger planning committee, a number of the Commonwealth Funds grantees, but also our subcommittee. And I think of Jerry actually in particular, we really debated how to start. Do we start with utilization? Do we start with cost? And we really had a focus on starting with the needs, the conditions and the needs, in part, although we couldn't always be true to that because some of the data we were looking at actually started among the top 10% of those who spend and then looked at their needs. So, but really try kind of at least, I think philosophically, it's really much more about starting with the really complex medical and social and behavioral health needs of the patients, because for exactly what you're saying around regression to the mean and potentially some of the incentives. So that's on one. On the psychiatric, the leading researchers from the Harvard School of Public Health can talk about this more, but on the complex conditions, I mean, the psychiatric diseases were incorporated as among, as part of some of, to be in the major complex chronic, it was incorporated. And then, I mean, it was one of the ones that would kind of put you in that group. We are funding Ashish and Jose to do a follow-on analysis, looking much more exclusively at the relationship and the drivers of cost related to mental health disorders. But Ashish, Jose, I didn't know if you wanted to say anything in response to David's comment about programs or what you're seeing in the data around behavioral health issues. For our viewers at home.
It's green. Terrific. The big thing I guess I would say is we're still, I mean, the analysis, we're just kind of digging in, but as I think about it, and as I even go back to what we started with initially, I think what we're learning is that mental health is not like any other chronic disease, right? And it's really an effect modifier, to use a kind of a statistical term, that it changes the relationship between every other disease and spending and outcomes. So diabetes is a problem, it's expensive unto itself, it's a certain size of a problem, throw in diabetes and mental health, and you have a very different picture than if you have either mental health or diabetes alone. And so I think the data suggests that we've kind of thought about mental health a little bit, probably not quite right, as just another chronic disease, and it's really something that needs to be thought of very differently. And that obviously is going to have big impacts for how you design programs and how you identify and target patients. So I think that's sort of the big insight so far on based on the empirical work we're done. I don't know, Jose, if you want to add to that. Jose's happy with that. Okay, good.
Let's start here at the front here, Bruce, and then we'll go here. And then, okay. So you can grab your mic, and when you're ready, you can.
Is that on? Yep. There we go. So first, thank you for a great presentation this morning, and I think really thoughtful work in a space that's been plowed many, many times and yet not plowed successfully, if that makes sense. And I think, Melinda, you gave, I think, a really articulate sense of where we are and where we need to go. So this is a great jumping off point. So a comment for each of you, maybe, and looking for a reflection. So Melinda, if I heard you correctly, and I'm glad to tell me if I misheard you, but I heard you start at the very beginning of your presentation saying function drove sort of which buckets people would end up in, and then you were in those buckets. Did I hear that correctly?
So if you are functionally limited, you are and under 65, I'm just going to use I may be mischaracterizing this slightly, but or oversimplifying. If you're functionally limited and under 65, you are in the non-elderly disabled. You could have other things, but you are always going to be in that bucket.
So my comment would be on that. That's perfect. So I guess my comment would be back to the group and to Nam before the model gets finished, is I think I like visualizations. I think it's really helpful for people. It may be the only thing that people remember. It's the kind of thing that will get cut and pasted into other documents or used at presentations like this. So for me, a visualization has to tell the whole story without you there to narrate it, and that is not in the visual. And for me, that's a profound problem. So capturing the fact that function is above this and drives categorization. I mean, I know we want to keep it simple and clean, but I challenge the committee to go back and try to
Mike McGinnis walked out of the room, but I'm sure he would agree with you.
So that was my comment for you, because I think it's a great contribution, and I think capturing that comment will be important. So Arnie, I'm struck by something else where you landed at the very end. Which is, I think we've seen a number of lists, and some of the foundations in the room have contributed to the cacophony of lists of things that one could do to build a successful program. And having actually worked in a health plan in another part of my life and having sort of contributed a little bit to some of the mess, I sort of have two observations. Is these lists, however long they are, sort of treat all the elements as equal. You need basically the majority, if not all, of these 7 things to have a successful program. But I think 2 things are really true. They're not all weighted equally. Actually, if you talk to anybody who's built or run these programs, A, and B, the fundamental success of any of these programs is about response in real time. So you can do all those things, but if the health system says, well, we only do this 8 to 5, or the after hours backup for our comprehensive 24/7 team is a person who knows nothing, and having worked in a health plan where, the backup is a call center in Poughkeepsie, no offense if there's anybody watching from Poughkeepsie, that's not going to work. And so oftentimes these programs fail because of the weakest link, regardless of how strong the strongest links are. So I'm wondering if this may be more than the NAM group could do in the time available, but I think one of the things that parses success from lack of success is sort of this strength of all the elements and the kind of the weakest link question.
that good? Can you hear me? Okay, good. So it's a really good point, and it for me triggers another thought I took off the list, so I won't get more interaction from the group. But that is, if one wants to imagine how we might more rapidly learn, collectively as an American health system, how to better match characteristics of programs with patients, including the program must be immediately responsive 7/24, versus for this patient segment it may be less important. For example, let's imagine a patient segment where the pivot to addressing high cost to affecting a patient's health and health spending trajectory is to take a single pill once a day, reliably, perfectly. You don't need 24/7 responsiveness for that. But as you begin to think about what a learning health system would need to do in order to more rapidly evolve care models, care delivery methods that are tailored to specific patient needs, you begin to realize that you would need to move to, first of all, begin to develop, just as the NOM did for patient psychosocial variables, ways of characterizing particular delivery systems. Are they on or off so many hours a day? We don't yet have clarity on how one might go about specifying a set of data elements that would allow you to take what we believe today are important characteristics of care delivery teams and pull them into a database so we can begin to use modern computational methods to better match, particular patient groups and eventually individual patients to a set of team characteristics. It's the next frontier. That crosswalk is essentially that's what we'll call the non-computational approach to translating to fitting care models to patient needs. But we are very close, I think, again, depending on data exchange and also whether we do make progress in characterizing, what are some properties of, we do it, that's what, we've made progress on characterizing the psychosocial status of individual patients. Why can't we do the same for an initial set of care delivery characteristics, so we can begin to see, where, using the flow of natural care, which delivery system characteristics appear to be getting better results for which sets of patient characteristics.
Bruce, your question is the Holy Grail, right? I mean, it's people, and you totally are wearing your old plan hat, because people always ask, well, which component makes the difference? I can't fund all of this. Can I fund 3/10 of this? And we just don't, and I have tried in other settings, particularly around like the patient-centered medical home, and it's really hard to do. It's hard to tease out. It's hard to have enough variation and individual, kind of both in your outcome and analytically, it's really challenging. And so, that's why we end up with these syntheses as we do. But I don't disagree with what you're saying, that you're maybe only as good as your weakest link, and there's probably some synergy with some combination, and we're looking for that secret sauce, but we don't really know it yet.
Hey, thanks. Allison Hamblin with the Center for Healthcare Strategies. So first, thank you for being so bold as to put a taxonomy out there that many people are going to just naturally say it's not perfect, as you acknowledged. It's hard to get there, but I think it's a great starter, so thank you for that. That said, here's my...
Here are all the patients we left out. Go ahead.
So this theme has come up in a few other responses, but just to sort of add additional weight to the suggestion of having behavioral health, and whether it's serious mental illness or substance use disorder, or I would say even potentially some of the social factors as potential drivers at the top. And the reason I say that is I think the audience, as you laid out here, is sort of system level, policymaker, health system leader, and part of the information that they need, from my perspective, is how to design a program and how to design an accountable entity for sort of owning this responsibility and being the center point for coordination for a subset of high need individuals. And I think the risk of having behavioral health and social factors sort of as overlays and not as entry points, I think may detract from the ability to kind of from the front end assign responsibility and highlight the need for cross-system partnerships at the very beginning of the system design. And so, again, there's been comments about the power of the visual. And on the one hand, there's power in saying, you know, behavioral health is ubiquitous, social factors are ubiquitous, we need to worry about this for everybody. But at the same time, while that's true, there are folks for whom those factors are really the driver of kind of what we're seeing manifest in high utilization of healthcare services. And so I think you could potentially do both. You could have the overlay kind of recognizing that they're factors for everybody, but at the same time, recognize that the entry point for some folks, you know, starts at the top and is sort of the root cause or driver of what we're seeing on the healthcare side.
Yes.
So do yeah.
No, I mean, we really, Dave Labby sits on both committees. He sits on the Commonwealth Fund's External Advisory Committee, and he sat on this subcommittee. And we had initially, when we presented it to our External Advisory Committee, this is the Commonwealth Fund, we had put behavioral health in a different place and social complexity in a different place. And they were like, it has to cut across. Now, maybe we still visually, I think we still need to work on the graphic, on the functional limitations, and also really call out, we're not trying to demote in any way the importance of behavioral health. So we have to work on that. But I understand also what you're saying, and maybe just be more clear also about, in the chapter, we'll be clear in terms of the language that goes around it.
I mean, that's in a way, that's the function of those three circle diagrams. Big circle means you start there, right? The big driver of some populations is behavioral health. You start there, right? The medical stratification is there, but it's a secondary issue. And so I think that's always been when we sort of figured out that piece, that biopsychosocial model, and really starting there, it really helps people saying, this is really about social care. This is not about the medical system as a primary driver, because that's the major issue.
And we have a lot of tipped up signs. Why don't we just arbitrarily start there and just go around it? Start with
Randy.
Janet. I think Janet next, or
Randy.
Randy?
How about Randy, Gretchen, Janet?
Okay.
Hi, Randy Brown from Mathematica. I really like the focus, Melinda, on the complexity and the diversity of the population and the need to target the programs to that. So I think that's great. And I also like the focus on just the highest risk, like David was pointing out. The Holy Grail has always been, okay, great, but can't we prevent people from getting there? And that's really hard. It's hard enough to find effects for the top 3 or 5%, but the next group is even harder. And I don't know how long that would take for those effects to play out if you could ever get them. One of the things that you didn't mention that I thought was worth looking at too, though, is that the fact that for a given patient, it changes over time too. You know, so like you get the categories there, and that's great. You have this kind of lexicographic way of slotting them into things, and I don't think I'd necessarily do it that way, as opposed to what's the patient's need. You know, somebody that is disabled and under 65, if they also have congestive heart failure or something too, that could be the thing that drives their risk and that drives their quality of life. And so maybe that's the cell they need to go in. Maybe I haven't understood exactly what you had in mind by that, but the idea of it sounded like it was kind of, if you were disabled, you went in that category first, even if you had the other stuff. And so it doesn't mean you were going to ignore it, but it just, you know, so maybe it should be slotted based on, you know, what's the thing that drives for them. And that's going to change over time too. So, but I think that the time dimension is something that you can kind of deal with in a way with with the nurse coordinators. Sometimes they can triage and everything, but one of the things that programs struggle with in terms of keeping costs under control is that those super high intensity cases wax and wane in terms of their needs, and that can affect your caseloads and things like that that you can handle.
I think that's a really good point, and I think it is why I think we will inevitably move to more of a continuous computational model. You know, a number of people have published, you know, a vision for this. Sebastian Schneeweiss at the Brigham has published a provocative article on this. But there's once we begin to have a more continuous flow of variables that that get a little bit deeper than the traditional health insurance database, which is what you have to run your CRG grouper off of. I think there is an opportunity to begin to pick this up, and then you add in some of these intriguing developments with respect to continuous capture of data via inexpensive sensors, and you can imagine how this might work. I mean, I think the most graphic illustration I heard, Randy, of what you just described was a situation where there was I think this was described to us was an 85-year-old woman with a 90-year-old husband who was demented. The two of them are living at home, but barely. The governor of their state is praying that they don't need long-term care because it's adds an additional $90,000 a year to somebody's budget. And it turned out that the pivotal variable that was quite instant and transient that you had to solve for to sort of prevent nursing home placement was in this very tenuous equilibrium where the wife was just barely hanging on. Her disposal her garbage disposal stops working, and her sink backs up, and that was sort of the breaking point. And what would the point that we heard from this imaginative delivery system that had figured out that an immediate response responsiveness was needed was the kind of nurse that is that can get out there in 10 minutes and is enough of what I'll never forget this word. Enough of an action junkie that when she saw the problem, she didn't say, call a plumber, oh, by the way, you don't have enough money to pay the plumber, it's a weekend, but rather she got under the sink, found the tool, that you wouldn't expect an 85-year-old person to be able to work, unclogged the disposal, washed the dishes, put them in the rack, and said, are we good now? And the answer was yes. Yeah. Exactly.
Great. Gretchen, and then we'll go to Janet, then David, and then
Gretchen Alkema with the SCAN Foundation. I love the idea that you hire somebody on their ability to use an Allen wrench underneath the garbage disposal. That's awesome. Thank you guys so much for your presentation and obviously the extensive work of the committee and the Harvard colleagues to bring it together. And I am so appreciative of the bringing together the medical and the functional in that very top component across all of those groups. And certainly the SCAN Foundation and many, many others in this room and many of our grantees have worked hard to get under the hood of function and understand that better, and knowing that it's an enormous separator of high and low cost, even within that top 5% of medical-related risk. So then that gets to the next piece, which is how many health systems and health insurers and primary care physicians actually have that information on function, and what do they think function is? I mean, function is really the Wild West when it comes to information inside of data systems. And we did some work with Avalier that basically said it's very little that is out there in regardless of whatever it is, and then certainly not in a standardized way. Much more so in health systems and plans that have engaged in dual eligible demonstrations or in Medicaid MCOs because of the nature of the kinds of populations and services they're delivering. So this is obviously a huge plant I'm laying out for you. Do you have any recommendations that you would want to have in the report about the involvement of function in data sets as well as standardization of that function, given that we've got great stuff from Duals Demos, NHATS, Urban's got some great Dynasim data. I mean, there's lots of places to go for this.
I may be misremembering, but I thought when I read Ashish's interim report, there was a reference to the fact that if you wanted to begin to do this care customization for high-cost HUD needs group more carefully, one would need some way of continuously assessing functional status. Am I right about that, Ashish? Yeah, good. But that's on the list of variables that we need to begin to think about. And there have obviously been efforts to do this. I mean, you think about John Wasson, with his "How's Your Health?" Begin almost every visit with a set of simple, intuitive questions that could be answered, when the patient registers, that would be designed for to address low literacy, that would allow you to quickly compute something like an SF 1 or an SF-12 score. And then the SCAN Foundation, particularly for this group we're talking about now, one would want to move beyond that to begin to see, could you do something similar with respect to ADL capability? But that's, the beginnings of that are there, and the question is, can we create enough, kind of perspective change, in the American healthcare system, such that people begin to be eager to do this because they realize if they don't do it, it's going to affect the patient flow from the private payers in terms of more selective networks and payment amounts from Medicare per the the value-based incentive system that MIPS is now we're now betting on via MIPS.
Right. So Steve Council and I would love for that to be at the top of the recommendations in this report. Thanks.
Duly noted. We're going to work this way now. Janet to David, and then work back over.
Great work. Really stimulates a lot of good thinking. One of the things I worry about here that in segmenting the population and identifying these very specific different care models for them, that it will have the unintended consequence of further fragmenting the delivery system. You clearly pointed to freestanding programs, many of them as examples of the care models. And I guess I wonder whether, do you envision that we can develop organizational structures where these care models can exist under the same roof, and that we can think about the underlying resources that need to be there? It's basically the workforce, the team composition, the telehealth supports, the social services, and have a management structure that is nimble enough to be able to quickly assemble the right model and match it to the right patient.
You've raised an issue that that we have struggled with since the beginning, that in segmenting, and further specializing, are we fragmenting? And that is definitely not the intention. So the hope is that actually we would enable health systems to actually, as you say, bring in and buy or contract, some of these kinds of models. Then on the model piece, I just want to, there were two sets of activities that were going on simultaneously. Some of it was about attributes of successful models, so kind of agnostic to the trademarked model, and then some of them were about models that had, kind of name brands. And we did both, in part because, there are going to be some systems or ACOs or larger systems where they're really strong, like they're doing a lot of great work on, outreach and community-based connections, but they're not really that good on patient engagement or other things, so you kind of really pulling out some of the attributes. And then others where, like MedStar or Independence at Home, home-based primary care, where you have a really great system, but you want to actually, or PACE, want to contract with that and want to bring that in. So I think that it is an abiding concern, that we will inadvertently fragment. That is not the intention at all, and so we have to just be really on top of that and mindful of that. And then on the second piece, I think it's really kind of, if you want to do the model or you want to do the practice, and the idea is that they can integrate it in and go, and the real trick is going to be, how do you thread it together in a way that is seamless for patients, caregivers, and the providers?
You can imagine two different avenues of solution, and I'll be able to use the example of, we set loose 3 diverse postdoctoral fellows on a category of high-cost, high-needs patients. We said stage 4 CKD. That is a perfect fit for this chronic kidney disease. It's a perfect fit because these people are on the brink of needing renal replacement. They typically, when our research fellows actually interviewed these patients, it implied that every month they and their families were supposed to be able to get to, I think it was like 9 different categories of providers, endocrinologists, nephrologists, general internists, nutritionists, OT. I mean, it was completely impossible. The patients had given up, and our fellows stumbled. They were doing an evidence review, and they said, "Gee, look at the results they're getting in British Columbia. Can we go up there and?" So they went up there and looked, and they came back and they said, "The answer is clear. For these customized groups of patients, we need to regionalize, services." I said, well, excuse me, but that idea, has not worked, so far. It's worked in a few domains of American healthcare, but generally it's been a tough road. You think of a different way of solving the problem, and then what they said is, well, gee, could you imagine now that we have, pretty good and pretty cheap, televideo, that that there are that nephrologists have an embedded case manager who when the patients come in can actually understand what these different entities are wanting to do, and maybe bring them in via televideo. So it's short of the kind of regionalized solution that we may end up getting to, and we have done in certain categories like trauma care, but which so far has politically been a rough road. So I think the answer is either you begin to regionalize, or you have very big delivery systems that can do the equivalent, or you begin to use technology to think about how you might more fluidly bring in resources, without having to send people out to an even more fragmented delivery system.
Okay, we're coming. We have 5 more minutes or so, so we're going to take 2 questions at a time here to try to batch them. So David, and then we'll go over here. So David Myers here.
Thanks, Peter, and thanks to Arnie and Melinda. As one of the government folks here, I need things really simple. And I want to do a talk back to make sure I got it, because I think I'm getting confused. The money shots were Melinda, your vertical horizontal diagram, and then I think Arnie, the example from Colorado of going across. And Melinda, if I heard the charge, or your taking of the charge, your diagram is really not for individualizing for patients. It is not how do we think of getting a patient the right service. It's about how a system can evaluate itself and say, do we have it? Do we have it? Do we have it? Do we have it? Are we meeting the needs of our full potential population? Do we have models that they could go to Arnie's, sorry, that was probably the 3rd shot of the huge graph, and say, here are the populations, and list out what we have, and can we check boxes in a way that makes us feel that we're able to meet all of our patients' needs. And maybe we realize we miss the kids, or maybe we're missing end of life, and we need a model to reach those folks. And that's very, very different from what I think some people have been asking of it. And so maybe the answer is we need a better visualization of, once the system has all their programs, how it flows together to answer Janet's question, that we're not just thinking miraculously everybody will self-sort into their places, and that we're not going to give everybody everything, but and how we get that time dimension in. So it's the difference between system thinking, building your system, versus once you've got it, how it works for an individual patient. Okay, I'm glad there are yeses coming. That was okay.
Jones. I'm with America's Health Insurance Plans. This is really great work. Medicaid managed care plans and managed long-term service and supports plans have kind of been doing a lot of this stuff without the benefit of a taxonomy, I guess, following their noses over the years without knowing that they're following an impact model per se and so on. I think that one of the real valuable pieces of this will be in terms of standardization of program evaluation and standardization of assessment instruments, perhaps, so that state Medicaid programs, other government programs can kind of look at this very high level structure and say this makes sense for our populations, in managed care and managed long-term services and supports. One of the things I wanted to mention, following on your comment on cost savings, is that in our experience, there is always investment with this, and the savings are in relation to what baseline. If you're coming from a totally non-managed service system and you're going to impose service on it, there is going to be some period of initial investment where you're not going to have any cost savings. But over the long term, you're looking to bend the cost curves. I would also point out, and maybe you do a video for this, the dynamic aspect of where a given individual is going to fall in relation to the position of predominantly medical, predominantly functional, predominantly behavioral needs. For example, if somebody is homeless and psychotic, their diabetes is not going to be under control. But once their medication stabilizes and their schizophrenia stabilizes and they're able to go to appointments, check their blood sugars and so on, they're going to move to sort of a different position in the continuum, and the care management team emphasis can change, things like that. So there is this necessary, I think, a necessity to try to show the dynamic aspect of that. You know, in managed care plans, we're used to working with interdisciplinary care teams. Getting to your point about fragmentation, in managed care, we do not have an integrated system typically where everybody is an employee, everybody can get together for a meeting. So really one of the challenges is having somebody who is really familiar with the range of diverse community resources, who can reach out, assemble a care team from various disparate locations, get everybody focused on what the patient needs, realizing that you know, the psychiatric issues may be first and foremost. We get that stabilized. A month later, we're talking about getting onto orthopedic considerations, getting a wheelchair ramp installed once the person is stabilized and able to go home to a community-based setting, things like that. So, yeah, I think those are all the points that I wanted to make. But the dynamic aspect, the initial investment before realizing returns, and this ability to reach out and harness resources across the community as an alternative to having to have them all under one roof. Thanks.
Perfect. We're going to take two more and then take a break. So Melanie and Joanne here, and then we'll take a break. And there's more time to talk today, but we'll do two. So Melanie.
Hi, Melanie Bella. I have a comment or question with my former CMS hat on. So I'm thrilled to see I can see a world where we're effectively segmenting and matching patients to models. What I worry about then is the ability to engage them in those models. And what we're seeing in the duals demonstration is just really difficult, building trust. And so we can have the best models in the world that have had good outcomes, but I would just ask or encourage us to think about how to make sure that we know how to engage them in those models, and once also how to make sure that when they need to graduate from those models, we're thinking of the graduation as well. Because I think we've seen a lot of Medicaid programs, they just sort of carry it. And it's hard to let go of folks, but you need to kind of know when there's an endpoint for any number of reasons.
I completely agree. When I went out to, both on this specialization question and this graduation question, we did a site visit to CareMore, because it's, you know, very highly specialized primary care. And I was very worried that it was further fragmenting and undermining local primary care. Actually not the case. They really rely on kind of the larger network of primary care in the community. And I specifically said, I said, and what's your criteria for when someone kind of, you know, graduates, moves on, you know, from the program, and they gave it to me. So I think a number of the programs, if they're really, really good, one, they've kind of they do a good job on patient engagement and caregiver engagement. I think that's a big area of improvement. We need to do more research, but also they really should be kind of both integrated in the care network, in the community, but also have that criteria for when you're in and when it's time to cycle off.
Yeah, I really think this does, you know, there will be soon an opportunity for a continuous computation and, you know, the ability to essentially say to whoever the patient does trust, you know, gee, this patient at this point would be better off if, you know, if advised to come back to their original primary care team or not, or this should be added to the care mix, custom mix, you know, based on continuous information that is being, you know, pulled out of the home, out of the electronic health record, out of sensors, et cetera. We think we will get there, and I think it will identify patients not only who unbeknownst to their primary care team need to be pulled into a more intensified care model, as well as for those patients that are in need to be discharged. You can see the beginnings of it now with these systems that now begin to guide ICU decision making. They're continuous computation based on variables, coming out of the hospital EHR and some of the monitors the patient is picked up on, where the people who are trying to make ICU admission and discharge decisions, we're now at the beginning of them, actually having probability calculations of what if we don't admit them, what if we discharge them, what are the chances that something good or bad will happen. We're not quite there, but you can see out of this research that we will soon be there, as once we do a little bit better on getting these figuring out where to get these cheap sensors installed, and also the data exchange problem, which remains a huge policy barrier to the customization of care to fit patient needs.
And you have the last word.
I'll try to be very short, but I'm troubled with a persistent quandary that there feels to be a lacuna. This is clearly a major step forward. I mean, it clearly is a good thing. But it seems that this idea of regionalization you've skipped over kind of quickly, and the role of the community. It isn't just that this person is homeless or this person is food insecure. It's that the community doesn't have housing for disabled people, or it doesn't provide adequate home-delivered meals. There's a geographic community aspect, at least for the seriously disabled. And there's also a tremendous efficiency aspect. In Washington, D.C. here, we have 60 home care agencies that have to serve every single home in D.C. And we spend half of our Medicaid dollar on the inefficiency created by the illusion of competition. It takes a little to think that through, but it's a tremendous waste. It seems that, in a sense, the presentation has been kind of passive voice. Someone ought to do this. And it seems that the someone, at least for some populations, needs to be geographic. And maybe that's why PACE works so well. It's our only geographic program, and it makes promises clear to the end of life. So you don't graduate from PACE, except to eternity. But the confidence that people have in PACE and hospice, where you have comprehensive services to the end of life, and essentially the team is saying, nothing can happen so big that we aren't with you on this. And some of the people have high expenses, and then they go to low expenses, and they're still in the system. They're still working with the same people. There's something worth recognizing there. So I'm concerned that there's something around the fringe of this model that is still really important and hasn't quite made its way in.
I think you did a beautiful job of setting up our next panel around policy, environment, and support. So I know I do think that's, but let's thank this panel. We're going to take a 10-minute break. 10-minute break. And then we will come back and talk about policy supports broadly in the community, federal and state level. So 10 minutes, and we'll see you back here.